Mixed hearing losses can take many different formats. Stable mixed losses, which are often congenital in nature, can be generally managed well by behind-the-ear acoustic hearing aids in the same way as we would manage stable sensorineural losses. However, when we have a stable sensorineural loss that acquires a temporary conductive overlay, which is likely to also fluctuate, hearing aid programming becomes much more challenging. In these cases, it is wise to adopt a safety-first approach and to use caution when making any changes to the hearing aid programming. It is important to bear in mind the risk of loudness discomfort should gain increases be applied and the conductive component then suddenly improve or resolve, leaving the hearing aids programmed uncomfortably loud. Babies and young children in particular cannot self-report reliably, whereas older children may be better able to. However, this should always be considered on an individual, case-by-case basis. It is sensible not to jump into making significant changes too early when a conductive overlay appears on top of an existing sensorineural hearing loss. Reviewing these cases regularly can help to establish the pattern of the conductive component. Is it fluctuating or is it relatively stable? Are you seeing improvements over time or deteriorations? Regular reviews can also allow you to establish how the child's overall development and progress is taking place, and this can help inform whether further intervention is required. If a child is making good progress despite the conductive overlay, then perhaps no changes are required. However, if their speech and language and/or their school progress is suffering, then it may be worth considering altering their hearing aid provision to provide further support. Consider also the long-term management. If the child is shortly to undergo surgical intervention to address the cause of the conductive component, it is probably safest to not make any changes to the hearing aids, especially as the expectation will be that the conductive loss will resolve with the surgery, which could leave them with hearing aids which are much too loud. However, if there is likely to be a considerable waiting time before surgery, or that decision has simply not yet been taken, then some hearing aid changes may be more suitable as an interim measure. If the decision is taken to adjust the hearing aids, then above all, loudness discomfort and the associated risks must be considered at all times. Volume controls can be issued to those patients who are able to manage them carefully, which again is typically limited to older children. Another option is to provide a secondary program with altered settings, maybe a louder option, or with stricter noise reduction settings for specific circumstances. Once again, the ability to manage a program button or utilize a control app safely and sensibly is really important. If the decision is taken to reprogram the hearing aids to a new audiogram with worse thresholds, one needs to consider the audiogram being used. When a conductive component is present to the loss, additional gain is provided. However, in order to proceed with caution, it may be sufficient to program the hearing aids to the new, worse air conduction thresholds only, and actually disregard the bone conduction values. On the other hand, the goal is to provide sufficient amplification to support the child's progress, so it's important to consider whether the bone conduction values should be included in order to achieve this aim. When performing verification in these cases, many clinicians will ensure that the MPO and the loud speech output, for example at 80, are significantly below target in order to provide a conservative fitting whilst hopefully still improving audibility for soft and normal speech input levels. Performing RECDs on temporary conductive overlays poses a challenge for clinicians, as the presence of middle ear dysfunction leads to large intersubject variability and alterations in the RECD curve, most generally seen as a positive increase in the mid to low frequencies. Now, there are some options available for these cases. It is possible to reuse a previously measured RECD from when normal middle ear function was recorded, However, remember that the goal of an RECD is to provide an accurate, up-to-date measurement of the acoustic properties of the child's ear canal. And as such, using old REC data is not generally recommended. But in these cases, it's important to assess the situation and establish which is the better option. Recording an up-to-date RECD with middle ear dysfunction, or utilizing an out-of-date RECD with a normal middle ear function. It is always worth measuring a new RECD and comparing it to the previous data, and also comparing it to predicted REC data to establish which option is the best to utilize. If neither an old RECD or a current RECD with middle ear dysfunction is deemed suitable, then using predicted RECD data does remain an option as well. Lastly, it is important to remember to keep the overall picture of the child's well-being and development at the forefront of everything we do. Working with a multidisciplinary team approach provides a holistic view and feedback from numerous individuals and professionals involved in the child's care: the parents, school teachers, surgical input, and important not to forget, the child themselves, when that's appropriate. In addition to, or indeed instead of, changing their hearing aid amplification, there are other elements of a child's world that can be worked on to improve their chances of managing a temporary conductive overlay. The people around the child may need to pay extra effort and attention to communication tactics in certain situations. It is important to keep the school informed and up to date so that appropriate classroom management strategies can be implemented to support the child. This could be preferential seating, extra time, improved acoustics, a classroom sound field system, or personal loop system. Many children with hearing aids already have access to an additional personal microphone system for use in classroom settings. If they don't, this could be something to consider on a temporary basis, or just to make the extra attempt to ensure that it is being used and is all working properly. Essentially, when there's a temporary conductive overlay to an existing sensorineural hearing loss, there are a number of different options to consider, but rarely one clear-cut route to follow. Addressing each patient's circumstances on an individual case-by-case basis is so important. And whether changes are made to the hearing aids or not, it's important to make that extra effort to ensure the support around the child is working well and cohesively to encourage their progress and development.